Hello, everyone, and welcome to Bringing Life to the Lifespan. My name is Erin Armenti, and I am the spouse of an adult with CF. I will be moderating the session this evening, and I'll be introducing our other speakers in just a moment. This session is also being recorded and will be available to all registrants after the event. Before we get started with the session, I want to go over a few items related to the technology and how we can all interact. First, closed captioning is available and should be showing automatically on your screen. You can hide these subtitles or adjust the view by clicking on the CC icon at the bottom of your screen. We will be taking audience questions during the session, so please submit your questions at any time into the Q&A box. We won't be able to answer questions about individual diagnoses or treatment plans, and we encourage you to use the information you learned today to have conversations with your care team. Otherwise, we will do our best to answer as many questions as possible verbally, and we will also be trying to answer questions by typing answers directly into the Q&A box. So check back there if we haven't answered your question verbally. You'll also notice the group chat for everyone who is in the session. Please note you'll want to change the chat drop-down menu so that your messages go to all panelists and attendees. That way, everyone who's in the session can see your comments. If you have a question for the speakers, please make sure you use the Q&A box to submit it, not the group chat. If you have any technology problems during the session, please return to the event homepage and click on the live support chat icon on the bottom left of the webpage to connect with the tech and program support. There will also be a few polling questions from us panelists, which you'll be prompted to answer throughout the session. These polling questions will help us get an idea of who everyone is and what you're excited to learn about today. So when you see those, please answer. The poll will then go away, and once we have everybody's answer, we'll share them with you. So joining me today is a great group of people. I'm joined by Lauren Washington and another adult with CF, Corey Muirhead, a CF pharmacist, Deepika Polanani, a pulmonologist, Erin Tellerico, who's in charge of the Advanced Lung Care Guidelines in the CF Foundation. And then you won't hear from them, but Sue Sullivan and Elizabeth Yu from the CF Foundation will also be moderating our Q&A and answering the questions that you put in there throughout the session today. So without further ado, let's get started. We're going to start with a look at the epidemiological research for CF, and Deepika and Lauren are going to go through some of that with us.
Hi, everyone. It's great to speak with you today. I'm Deepika Polanani, and I am an associate professor of medicine at the University of Kansas Cystic Fibrosis Care Center. And I cannot tell you how excited I am to talk with all of you about a topic that makes me so happy. As someone who is passionate about CF care and research, nothing could make me happier than talking about living longer lives with CF. So the topic that I would like to discuss today, along with my colleague and companion here, Ms. Lauren Washington, is about aging, I would like to say not gracefully, because I'm not always graceful, but aging courageously with CF and emphasizing that it's your story. If we can go to the next slide. I do have the disclosure that I have done advisory board participation and consulting work for Vertex Pharmaceuticals, and we will be discussing some of their drugs today. Next slide. So this first slide is really representative of the type of data that we're going to be talking about in this portion of the talk. And this is data from the United States Cystic Fibrosis Foundation's patient registry. So the thing that I want to say first is that everybody out here who has CF and is participating in the registry, you are the real heroes that are helping to bring this data together. And that data feeds upon itself to help inform all of us across the CF community, care providers, researchers, people with CF and families, so that we can really understand what's going on and continue to build upon knowledge and keep improving the lives of people with CF. This data shows the proportion of children versus adults with cystic fibrosis from the years 1989 to 2019. And what's so exciting to see here is that you see that the proportion of adults keeps growing with CF. We have people that are being diagnosed earlier and living longer lives overall. And so we know that we are a growing and aging CF population as time continues. We can go to the next slide. But what does getting older actually mean? One of the things that I hear the most when we talk about survival in CF is that the terms are very confusing. So what we've done in terms of research letters, accompanying articles on survival, and even on the foundation's website is try to explain these terms so that people can better understand what it means when we talk about living to a certain life expectancy or the median survival in CF. These terms are often used interchangeably, but they're not actually the same thing. So the median survival in CF is actually the estimated median age beyond which we expect to see 50% of babies with CF who are born today to live under the assumption that the recent age-specific mortality rates are going to continue to hold for the rest of their lives. What does that mean in even simpler terms? If I could tell you how long babies would live with CF based on everything we know today, a median survival means that we expect at least 50% of babies to live that long and 50% to live even further beyond that. The mean life expectancy, on the other hand, is the average age to which people with CF are expected to live from birth. So what's the real difference here and why does it matter? Well, means or averages tend to often be skewed. What we know is that life expectancy in CF can be very influenced by just a few deaths that occur at older age. Generally speaking, across the literature that's used, median survival is generally agreed to be a better summary statistic for survival ages. And what we know today is that from the years 2015 to 2019 taken together, the median survival for a person born with CF would be 46 years. And as of the age of 2019, the median survival is now 48 years old. Next slide. So this looks like a pretty dull or difficult slide, but what I wanted to make sure that we talked about is a little bit more about how we arrive at these numbers. Epidemiologists and biostatisticians use different approaches to generate the data that comes even into that same term, median survival. And it can be looked at in a number of ways. So this is describing two different approaches. We can look at things by a period approach, which is really just taking in the top panel, this gray area that looks at all people who were living between January 2011 and December 2015, and including their data. So you can see that under a period approach, the solid lines for individuals 1, 3, 4, 6, 8, 9, 11, and 12 are all going to be included, but people who were not living prior to that, who are not living during that period will not be included in the analysis. On the other hand, when we talk about birth cohorts, you can see here in the lower panel that if you use a birth cohort set of people who were born during January 1st of 1990 through December of 1995, that includes a different set of individuals where you would only capture individuals 4, 5, 6, and 7 who have the solid lines, whereas everyone else has dotted lines. And the point of all of this is to say that you're looking at two different panels with 12 people who have the exact same lifespans represented here, but the numbers that can be calculated in very different ways. And when we tend to talk about median survival using registry data, we are typically using period approaches. Next slide. The great news is that everything that you're doing to keep living your long and full and productive life with CF is exactly what you need to keep doing to keep living a longer and fuller and more productive life with CF. So what we discuss here is really that we can talk about survival that is conditional on survival itself. Basically, the longer that you're going, the better the odds are in front of you. So what you can see is that the top panel shows that the estimated median age of survival that's conditional on survival to the age of 30 is 55, but the estimated median age of survival that's conditional on survival to the age of 40 is actually 61. I find it actually easier to see in the lower panel where you can see that once somebody is being analyzed on survival to the age of 30, you can see that arrow drop down and you see that the 50% line is hitting in that mid 50s range. But once they are living even further on to the age of 40, that 50% line is dropping down to the age of 61. Again, the best point from all of this is that the longer that you're living with your CF, the better your survival odds are in front of you, because it's already conditional on the fact that you have made it as far as you have with all of the work that you have done. Next slide. So as we keep talking about survival and living longer with CF, what about living with the quality of health that we're also talking about here? This is a slide that looks at the scenario of health status for evolving patient landscape. And these are preliminary estimates that were developed in 2018. Here, we're looking at data in pediatric and next in adult populations, where we're looking at lung function and the number of people with CF based on their health status. These estimates are consistent with the pediatric population size having an overall improvement in health. You can see that as time goes on, we are looking at increasing people who we expect to be healthy, that is with a FEV1 or lung function that's greater than 90% predicted, versus moderate, that's between 40 to 90%, and advanced lung disease, which you can barely see here in the thin, narrow blue line at the top of each of these graphs, and that's FEV1 less than 40%. And if we click again, we see that we also have an increasing number that we expect with adults. So by the end of 2016, we knew that there were 18,000 adults. But as this goes on, we expect those numbers to keep growing in a 5-year, 10-year, and 20-year vision, with equally growing proportions of healthy individuals, lung function greater than 90, moderate diseased individuals with lung function 40 to 90, and people with advanced disease or transplant with lung function less than 40%. So what we know, again, is that we project that there is going to be continued improvement. This data also harkens the types of research that we are conducting in biostatistics to better understand what it means to have lung function with CF when it's compared to people with CF themselves. Oftentimes when you're in clinic, you're hearing about an FEV1 that's percent predicted, just like we're talking about here, but that's also percent predicted relative to a non-CF population. And what we are beginning to look at is how to compare the numbers that you have in your lung function with CF relative to tens of thousands of other people with CF, and even account for the fact that your age alone means something in that number. So that if you're 65 with a certain number of lung function, that's not really the same as someone who's 14 with that same number in their lung function. And these are all the types of things that researchers are working on now so that we can offer you better interpretation of what it means to be living and living longer with your lung function with CF. Next slide. We can go to the next slide. Thank you. So what does this mean about how old everyone with CF is in terms of what we know now in the United States in 2000, as of right now? So this is 2019 registry data, and this is the age distribution of the CF population. And what we can see here is that there's absolutely what we call a skew, where we are seeing much greater numbers in younger individuals with CF. But what's so remarkable and what gives me such thrill here is to see these high numbers of people who are living well over their 60s and even over their 70s with cystic fibrosis. There's so much more buried in this slide that we could talk about. We know that identifying earlier diagnosis of CF through newborn screening is helping to promote these bar graphs, or these bars in this graph that are on the young end. We see nearly 500 people in 2019 that were born in that year with CF. We also know that closely adhering to the practice guidelines is helping people live longer. So is the active treatment of infection and attempts to better control inflammation, and overall the CF community coming together to really embrace quality improvement initiatives and help people live longer lives. We also know that genetic testing is improving the diagnosis of people with CF, whether it's at these early ages or even catching CF later in life as we catch more atypical cases in older individuals. So all of these factors are really helping us understand the rich information that is really contributing to this beautiful graph of everybody living with CF in 2019. Next slide. We also know that there are places that are understudied to date and making active efforts at better understanding what's happening in these spaces. So when we look at what's happening for minoritized people with CF, we can certainly see that in people of Black race or Hispanic ethnicity, we have a higher number of younger individuals. And just like the overall graph shows, there is a decreased number as the aging numbers go on the x-axis. Part of this actually can be related to newborn screening and improved diagnosis through genetics that are able to detect more than what used to be tested early on, for example, in the most common 23 mutations. So we're able to pick up more cases, and we are also now picking up delayed diagnosis in people who are of minoritized race and ethnic descent with CF, and learning more as we go. As we learn more about it, next slide, we also know that there's so much more to do. So this slide represents research that was driven by Dr. Raksha Jain and colleagues. And what we see here is that when we look at the overall survival probability of people in the US CF registry, that's 30,000 people for this data, we see that there is actually a better overall survival probability for people who are not of Hispanic descent versus people who are of Hispanic descent. And you can see that as we start to approach the 5th decade of life, these numbers start to get more close and approximating each other. But these gaps are really an area that we need to better understand and better study to know why, when in this analysis, even after adjusting for Pseudomonas aeruginosa infection, for example, people who are non-Hispanic had a better survival. Another space that is being actively studied and researched and featured in ResearchCon in other sessions also is the difference in gender in terms of survival. So we know that females with CF have been shown to have a decreased survival, also studied and published by Dr. Jain. And reports have been in existence over the last 3 decades of females having more difficulty with their CF health and lung health and survival overall. So this is an active area of study, and both these topics of race and gender are focused on during this ResearchCon this year. Next slide. One of the questions that is at top of mind is the new CFTR modulators that have come about in recent years and how this affects survival. So I'm very glad to tell you not only that we have those drugs available to many people with CF, but especially for those who are listening today that are not eligible to take those drugs, whether it's based on genetics or any other reason. All of the data that we have shown so far that is showing improved and increasing survival for people with CF has been based on data before we could factor in data on Trikafta particularly, which is available for the majority of people with CF in the United States now. So that is to say that everything that we're looking at is to tell you that there already is a brighter future. And as we look forward into the future, we will have data to come to understand how Trikafta may impact survival. So far, we've been able to look at data analyses of ivacaftor, which has been around longer for us. And we know after 5 years plus that in looking at the United Kingdom and United States registry data, there is a decreased mortality that is evident with ivacaftor. I would easily say that we are hopeful and expectant for the same of Trikafta, but we simply don't have the data in front of us yet. I would encourage anyone who's interested to look at the practice guidelines that were just focused on the last slide, but it's important to know that based on those guidelines, the combination of elexacaftor, tezacaftor, and ivacaftor, or Trikafta, is available for people down to the age of 12 years old with CF, where tezacaftor, ivacaftor, or Symdeko is available down to age 6. Lumacaftor, ivacaftor, or Orkambi is available down to age 2, and ivacaftor is now available down to 4 months old. We know from press release and a lot of excitement in the community that Vertex has applied for the expansion of Trikafta to include children down to the ages of 6 through 11. And for anyone who wasn't aware, it's right here that the FDA has granted priority review of the application and indicated that they will actually have a decision by June 8th. It's also exciting to tell you that there has recently just been a case report published in ahead of press in the Journal of Cystic Fibrosis that is reporting a baby who was born to a mother with CF who continued taking Trikafta throughout her term. And this female baby was born in the 95th percentile with testing that actually passed newborn screening for cystic fibrosis. So we are certainly looking at a very different chapter ahead as these drugs make their way down younger and younger. Next slide. So what does this all mean when it's taken together? If you look at a median predicted survival age over 1986 to 2016, for example, we see that the future of CF is bright and that it keeps building upon itself. Just like I was saying that survival conditioned survival expectancy shows that the longer that you're going, the better that you have your odds in front of you. We know that the drug advances even before modulators, including pulmozyme that was discussed in the keynote, and several others, including inhaled antibiotics, the use of enzymes, the implement of care guidelines, and working closely within the multidisciplinary CF care programs that we'll talk about more in our session today. All of these factors together are leading to this increasing survival even before modulators were in this timeline, with this data going to 2016. So this is an exciting time. Next slide. I like to say that age ain't nothing but a number. And I think that this slide is fun because it looks at two different types of folks who are growing older through their timeline. But as we can see, as you get to the 60 to 70-year-old range, we've got canes and we're leaning forward. And I'm not sure I totally agree with that. So if we go to the next slide, I think that this is a lot more colorful in a lot of ways, and I like it. And it really shows, I think, what it means to be living vibrant and expectant and growing into older age with lots of good things to come. So with that, I would really love to welcome Lauren Washington to talk about what it means to be living longer with CF. And Lauren, one of the things that I really want to make sure that we touch on today is your exciting blog and what you've written about in terms of what it was like to be young and what it's like to be looking forward with your life with CF.
Well, I was diagnosed at 5 months old with CF, so I've had it as long as I can remember. I feel like there's different levels of CF as far as where you stand. You're either in the hospital every month or you're in it for twice a year like me. So certain things, like certain conversations, are a little bit different for me to as far as mortality rate and infertility or anything like that. So it's been interesting since I've had my blog to connect and have conversations with different people and their different experiences and where they stand.
Thank you. And I know that we have lots of more exciting conversation ahead. So we will turn it back over to our moderators. Thank you so much.
Thank you so much, Deepika and Lauren. So moving on from the epidemiological perspective, Erin Tellerico and I, so double Erins, are going to spend some time talking about guidelines. So I think a huge theme of a lot of the talks in ResearchCon are going to be changed. So we're going to be talking through some of the CF clinical care guidelines. A poll should have just popped up. So if you can answer that in regards to your familiarity with the guidelines, we'll be walking through a little bit about how they're developed and give a very high level overview of some of them. And Sue, I believe, put some of the links to the guidelines already in the chat. So if you're interested in reading them for yourselves, you can just follow those links. But I will turn it over to Erin T. to start talking through how these guidelines are developed.
Great. Thank you so much, Erin, and thanks, Deepika, for getting us started. You can go on to the next slide, please. Disclosure, you can go to the next slide. So we're going to just talk really briefly about clinical care guidelines. Deepika brought up quite a few in her talk, and I think it's really important, that everyone understands and recognizes a lot of what is done in the clinic and to take care of people with CF and to support people with CF really is guided by our CF clinical care guidelines. So this is a quote from the Institute of Medicine about clinical practice guidelines that we follow very closely. And it's very simple. It states clinical practice guidelines are statements that include recommendations that are intended to optimize patient care. They are informed by a systematic review of the evidence and an assessment of the benefits and harms of alternative care options. Next slide. So how are guidelines developed? At the CF Foundation, we have a fantastic colleague of mine, Sarah Hempstead, who actually oversees all of our guidelines development. Most guidelines take probably at least 2 years to develop. So it's not like we just throw some words on a page and say, here you go. We really start at the very beginning here where you see our committee. We put together a multidisciplinary team of experts. So we have physicians, we have nurses, dietitians, we have patients and family members, adults with CF, all different types of care team members, depending on the guidelines that we are developing. And we feel it's extremely important to make sure this is truly a multidisciplinary team effort, and really rely heavily as well on people with CF, as well as support persons, social support people for developing these guidelines. After we develop the committee develops key clinical questions that we want to address in the guidelines. After that, this committee systematically evaluates the literature. So they go through all of the literature that pertains to the guideline that we are developing to try to help and answer these key questions. And they look at the benefits and the harms of the treatment. This is a big portion of the process where we have patient preferences come into play and are considered. The committee discusses and finalizes these recommendations and then starts to write the manuscript. Once the manuscript is written and we have it in draft form, we put that out for public comment, which means it goes out to all clinically relevant groups as well as community voice. So again, this is a great opportunity for people with CF, family members to weigh in, read the guidelines and give us their feedback. And we truly look at every single comment that comes in. Some of them we're able to, actually address and make changes to the guidelines. And then we always, like I said, take these into consideration. And then once that is finished, we make any edits that have to happen and then submit the manuscript for publication. So it looks very nice on one slide, but truly, like I said before, this takes probably 2 to 2.5 years from development of the committee to actually getting a guideline published in a peer-reviewed journal. So that's just a 30,000-foot view of how these guidelines are developed that you'll hear us talking about throughout the rest of this session. And then I think you can go to the next slide and we'll hand it over to Erin to talk through some of our age-related guidelines.
Thanks, Erin. So as Erin T said, I'd like to take you through some of the really early childhood guidelines. So the earliest one available is the Infant Clinical Care Guidelines. And I would really, again, the links are in the chat, and I would really encourage everybody to take a look at these. Based on the poll, it looks like the audience is pretty split in terms of those who have maybe used some of these and are familiar, and those who were not aware that that these maybe were in circulation. But they are really meant to be very accessible to the general public, and they're pretty easily digestible. If we could go on to the next bit of the slide. The infant care guidelines are divided into a few key categories, not surprisingly, beginning with initial diagnosis and moving on from there to things like nutrition recommendations, pulmonary recommendations, diagnostic testing, chronic pulmonary therapies. And when we're thinking about what these guidelines are, I'm not going to read each of them individually, but they give some overarching recommendations. So if we think about initial diagnosis, the big thing that's spelled out there is really what is the time from the time an infant gets a positive newborn screen to when they should be seen at a CF care center. And not surprisingly, that's a pretty tight timeline. It's 1 to 3 days, but that's really helpful to keep in mind when people are getting these first potential diagnoses. When we're thinking about things like nutrition recommendations, we're thinking about what are the recommendations surrounding enzyme replacement therapy, and what are the recommendations surrounding vitamin supplementation. When we think about pulmonary recommendations, we're thinking about airway clearance techniques, things like percussion and postural drainage, frequency techniques. We're also thinking about infection control, both in terms of, treatment, prophylactic treatment, and certainly the role in cultures in managing infection control. And we also start thinking about the diagnostic testing that I think we're all pretty familiar with at this point. So recommendations surrounding PFTs, when they should begin, imaging frequency, what should be imaged, how frequently, kind of in a maintenance phase versus in the context of an exacerbation is also touched upon. And when we're thinking about, if we can go to the next one, chronic pulmonary therapies, we're thinking about when to use things like hypertonic saline, when to use things like pulmozyme, et cetera. And it's also important to keep in mind that in some of these guidelines, there's also recommendations against using certain treatments as well. So specifically in the infant clinical care guidelines, there are recommendations against using corticosteroids because there hasn't been any demonstrated clinical utility in this population. So moving on from the infant clinical care guidelines, there are also preschool clinical care guidelines as well, and there's a large number of them. If we can go on to the next one, 53 in total. I am not going to read them all to you, but the categories are pretty similar. There are things like health maintenance, screening and monitoring, therapeutics, nutrition, behavior, and GI. So if we can go to the next slide, health maintenance is a really great one because I think, again, this is a theme that you're going to see throughout ResearchCon. This is really looking beyond just the CF care and also keeping in mind the overall care of the child and recommendations surrounding maintaining well child visits with a pediatrician, as well as staying current on vaccines with the additional importance of the flu and pneumonia vaccine as well for these kids. When we move on to screening and monitoring, there's still recommendations surrounding the frequency of imaging and cultures, but the recommendation surrounding spirometry, for example, includes when should we start that, and the recommendation is around the age of 3. If we move on to therapeutics, again, we're talking about, you know, what are we doing regularly for airway clearance in these young children, and how is that changing during exacerbations? Similar recommendations surrounding things like hypertonic saline, as well as antibiotics. And if we move on to the nutrition, GI, and behavior, we start thinking about things like BMI goals, as well as what are going to be the routine nutritional evaluations for these kids, and what are the appropriate interventions if certain goals are not being met. And then once we move out of the preschool age, once we move to school age children, there's more of a clinical care schedule as opposed to a specific guideline. And again, this is something that's really digestible. So definitely take a look at it. And if we can move to the next slide, it's really broken down again into recommendations and actions. So the themes are really similar, and I'm not going to read through all of them. We can just kind of bring them up, but it's very similar in terms of a lot of the themes that we're seeing in the guidelines, also touching upon education. And then the other really great thing in terms of implementing these recommendations are these action categories. So a lot of them are divided into do, as in you should definitely be doing this. Consider, you know, this, there may be a role for this depending on the specific child's clinical presentation. And attempt means we at least want to try it, but recognizing that especially for young children, some of the things we may be thinking about may not be feasible. And then there's also a recommendation for the frequency of these things. So many of these recommendations and screenings are flagged as to perform quarterly. So this is broken down really nice to give kind of an overall view of what we should be thinking about in the care of school age children, even though there aren't specific guidelines. So I'm going to turn it, before I turn it back to Erin T, I did also want to point out that another really great thing about these guidelines is that they also include unanswered questions. And I think this is so great because, as is abundantly clear, our understanding of CF in general is constantly evolving, and these do a great job of highlighting areas where additional research is needed. So, you know, what is the efficacy of some of these medications, specifically including modulators? what are the roles of, certain imaging and monitoring lung disease. So it's a great place to look, especially if you're thinking, hey, I have some questions that weren't specifically covered in the guidelines. It's a great way to get a glimpse into directions we think future research may take. So I'm going to turn it over to Erin T. now to talk more about some of the newer palliative care guidelines.
Thanks, Erin. So we're going to switch gears a little bit and talk about palliative care. And I know a lot of you are probably saying, why in the heck are we talking about palliative care? I'm here to talk about living my life across my lifespan. So I think a lot of old school thinking is that palliative care equals end of life care or hospice care, which is definitely not the case. Our most recently published guidelines focus on different models of palliative care. And what palliative care is, it really focuses on reducing the physical and emotional symptoms and improving quality of life for people with CF throughout their entire lifespan. And that's what this graph here shows you. On the x-axis down at the bottom, you'll see diagnosis all the way through to end of life and bereavement support. And that dotted line there is palliative care, is across the whole entire spectrum, right? Primary palliative care, which is the palliative care that's provided by your CF team. And palliative care really does occur alongside your usual treatments, and it is individualized according to your unique goals, hopes, and values. Some palliative care topics you're dealing with every day when you're in clinic and probably don't equate them to palliative care, but things like talking about your treatment burden, how we can help you with that, body image, social and school functioning and resilience, those are all palliative care. So it really is truly happening. It's just not something that we're really talking about, which is why I'm hoping that this will help people better understand palliative care. Next slide. So I think this graph is really great, this graphic, to show primary palliative care and specialty palliative care. And as I mentioned, palliative care is not just for people with advanced disease. This really shows how we can integrate primary and specialty palliative care to address all of the palliative needs throughout your CF experience. It really is continuously delivered, again, through diagnosis, which is on the left-hand side of this half circle, all the way through to bereavement. And the intensity of palliative care should really match the patient and family's palliative care needs. It's ideally a partnership between your CF care team members to provide the continuous first line monitoring and support for palliative needs, which is what we call the primary palliative care. So again, that's delivered by your CF care team. And then primary palliative care specialists come into play when we need a little bit more support and things get a little bit more complex and out of the scope of what the CF care team is comfortable with. So that's when they might look to a team that has expert experience in managing the complex concerns. And these palliative care needs in this graph, if you look at that white bar in the middle, kind of it goes back and forth and up and down and gets a little bit lighter and gets a little bit darker. And this really is meant to illustrate the variability throughout the lifespan and how it really does fluctuate depending on your disease course. Next slide, please. And these are some specific recommendations straight out of our palliative care guidelines. So this gives you an idea of what it actually looks like if you were to read through them. So one of them is that the CF Foundation recommends that CF care teams deliver primary palliative care as part of usual CF care. And I won't go through all of these, but it lists some of the things that we would hope that the CF care team is able to do. So communicating about your goals of care, your prognosis, helping you with goals of care discussions, basic management of pain and other physical symptoms, etc. Next slide, please. This is another recommendation directly from the palliative care guidelines that recommends that the CF care teams consult specialty palliative care, as we talked about already, and other specialists to address palliative care needs beyond the CF team's expertise. So we might pull in a specialty palliative care expert to talk about specifics related to the transplant evaluation process, or existential or spiritual distress that the CF care team may not be equipped to handle, looking into grief and bereavement needs and assisting with referrals out into the community. And then potentially introducing or revisiting hospice or end-of-life care. Next slide. And this one I thought was really important to put in here because these all focus on the caregivers, which are extremely, extremely important. And some of our recommendations call out that we really want CF care teams identifying and addressing caregivers' concerns and providing support and resources for caregivers. There's a lot that goes into helping support someone with CF, a lot of worry about the individual, feeling very overwhelmed and depressed, distress about helping to make these difficult medical decisions. And these are areas where we really want to help support the caregivers. And some external resources that we can point people towards are things like caregiver support groups, mental health services, and even community resources for at-home nursing care if someone needs that. Next slide. We're going to switch gears a little bit. So that's pretty much all I had to say about palliative care. There are more actual recommendations. You can find those guidelines. I think they've been popped into the chat, and you can also find them on cff.org. But we're going to switch gears and talk a little bit about advanced CF lung disease, because this is one of our other newer guidelines that has been developed. And so advanced CF lung disease, as we heard Deepika mention earlier, quality of life and survival of individuals with CF is continuing to improve, which is extremely exciting. However, advanced CF lung disease really does remain a reality for some of our community. And so we developed the advanced CF lung disease guidelines as a resource to help reduce the practice variability from care center to care center, to ultimately continue to help improve someone's quality of life and survival once they meet that definition of advanced CF lung disease. And this table is taken from our advanced CF lung disease guidelines, and it shows you basically as your lung function declines and your disease progresses, that's when we start falling into the category of advanced CF lung disease. And that's when we might start talking about things such as considering transplant referral. We have some specific management recommendations associated with some comorbidities that may occur once someone has advanced CF lung disease, really focusing on enhanced psychosocial screening and caregiver planning, again, including palliative care throughout this entire process. And really focusing on advanced care planning and potentially transitioning to transplant if that is something that the individual with CF is interested in. Next slide, please. So our definition of advanced CF lung disease, prior to these guidelines being developed, we didn't have a definition for what advanced CF lung disease was. So part of the guidelines development was putting together this definition, which is laid out here for you. So it's either a FEV1 less than 40% predicted when someone is stable. So this is not during an exacerbation. This is someone's FEV1 when they are in a stable state, or if someone has been referred for a lung transplant evaluation, or if they meet one or more of the following characteristics that are laid out there. So someone who may have been put into the ICU for respiratory failure, someone who is retaining a lot of CO2 is what we call hypercarbia, daytime resting oxygen requirement, pulmonary hypertension, and then a 6-minute walk test, which is a test that's done in the clinic to see how conditioned or deconditioned someone might be. Those are all criteria that would lead someone to be defined as having advanced CF lung disease. Next slide. So what does all of this mean? Great, we have a definition. What are we going to do about it? We've put together recommendations to help support the usual care. So the first bucket here is pulmonary and ICU considerations. And what we've done is we have recommended certain testing so that if you have advanced lung disease, you may hear about these in clinic. A 6-minute walk test, I mentioned previously, it's, you take a couple of laps around the clinic space or up and down the hallway. and your distance is measured in 6 minutes. And we use that to indicate your lung disease. And then nocturnal oximetry, which means what does your oxygen level do at nighttime? Sometimes people might wake up in the morning with a headache and think, oh, that's strange, and kind of go about their daily care and don't do much about it. When you have advanced lung disease, some of these things may be happening above and beyond just your lung function declining. And so our goal is to try to capture some different clinical markers, essentially, to let us know that, oh, it might be time to start adding some additional care for those with advanced lung disease. Associated medical conditions, again, although outcomes are improving, malnutrition remains a very important issue for advanced CF lung disease. So we talk about enteral tube feeds in the advanced CF lung disease guidelines. We talk about pulmonary rehab and really recommending that all individuals with advanced CF lung disease should be referred to pulmonary rehab. Next, and then some symptoms, psychosocial issues and advanced care planning. We do recommend advanced care planning conversations routinely occur when an individual meets criteria for advanced CF lung disease. And some of the things we encourage people to discuss during these advanced care planning conversations are your prognosis and your goals of care, documenting advanced directives, talking about your symptoms and your preferences, and decision-making. So if we get to a point where you might need admission to the ICU, is that something that you want? Do you want to be intubated? Do you want transplant? Is transplant something that we should start talking about? All of those things we want to be having early, open, honest conversations about so that we can help support you and make this time the best that it can be. And then lastly, there's, like I mentioned, transplant referral and pre-transplant care. And then I think with that, we'll end the advanced CF lung disease and move on to Corey, who will talk about the pharmacist role.
Thanks.
All right. Hi.
Oh, perfect. I was just, before Corey starts, I want to remind everybody to click the poll that just came up and take it away, Corey.
Thank you. All right. So hi, my name is Corey Muirhead, and I was invited to speak today to share with you my role as a pharmacist on a CF care team and how I can help you and make your life easier when it comes to medication access, management, and information. I work with our pediatric and adult care teams at Dorenbecker Children's Hospital and Oregon Health Sciences University in Portland, Oregon, and therefore provide care for newborns through adulthood. And I've been in this role since 2012. I do not have any relevant disclosures. So the CF care guidelines do not require a pharmacist on the CF care team as they do other multidisciplinary teams. However, in 2015, the CF Foundation included pharmacists as a recommended team member. And to help CF centers add pharmacists to care teams, the CF Foundation started providing grant seed funding for dedicated CF pharmacy team members, and they have grants for both pharmacists and pharmacy technicians. In 2019, in the registry in 2017, just over a third of people with CF were seen by a CF pharmacist at least once during the year. Between 2016 and 2019, the CFF awarded grants for 50 pharmacists and technicians. And in 2019, the CF Foundation provided an additional 54 centers with grant funding for a pharmacist and or a pharmacy technician, which totaled 104 grants. So in 2019, now almost half of people with CF were seen at least once by a CF pharmacist. So on the next slide, there's a graph representing the number of care teams with pharmacists and technicians. The pharmacists are in blue. And in 2020, there were 234 CF pharmacists and 53 technicians. The CF recommends, ideally, next slide please, that there be a pharmacist per every 100 to 200 people with CF. Some larger centers have 2 pharmacists and or a pharmacist and technician team. 128 programs across 46 states plus DC have at least 1 pharmacist or technician and provide care to over 18,000 people with CF. There's only 4 states who don't currently have an integrated pharmacist. And centers with pharmacy team members are pretty split. There are 55 adult centers and 57 pediatric centers, as well as 16 affiliate programs. So I am the only member of the CF pharmacy team for both our adult and pediatric centers and care for over 450 patients. I'm the only CF specialist pharmacist in the state of Oregon. The pharmacy team members are spread out across the country. However, we are connected to one another. We have an email listserv that we utilize. We have CF Foundation sponsored mentorship programs where we teach and learn from each other. We are involved in research with CF. We have our own discipline sessions at NACFC every year and have pharmacy workshops and symposiums to share our research. So I wanted to share with you the roles of the CF pharmacy team members on CF care teams. Here are the roles of a pharmacist and a pharmacy technician as previously published. As experts in medications, our priority is to ensure safe and appropriate medication therapy. We assess drug-drug interactions, herb-drug interactions, adverse reactions, allergies to medications. We monitor and interpret drug levels. We talk to people with CF and their caregivers to provide education, both for CF medications and non-CF medications. We talk with other care team members, other providers caring for a person with CF. We help make sure the prescribed regimen is doable, sustainable, and help problem solve barriers to sustaining daily cares. We assist with medication access. Getting specialty medications on time without interruption can be difficult. Published research shows that having integrated pharmacy team members leads to fewer days without specialty medications, as people are quicker to receive them, and people with CF under our care have fewer pharmacies. We help ensure needs are met for copay and grant assistance programs. We are here to answer questions and concerns. So in a nutshell, here are the roles of the pharmacy team. We promote medication safety, efficacy, provide enhanced education. We are a consultant and communicate. We help you find ways to sustain daily care regimens, provide support, access, and at least cost. During times of transition to new treatments or stages in life, your pharmacist can assist. I'll be providing some examples. So new diagnosis. We utilize the CF guidelines to ensure that people with CF are receiving optimal care. And I note the guidelines on the slide that are appropriate for the transitions I discuss. So new diagnosis as both an infant or later in life is an important period where I help explain medication coverage by insurance. I get a lot of worried questions about whether insurance will cover the expensive modulators and how much these meds are going to cost. Aside from the important medication access questions, I'm there to enhance the medication education that the person with CF and their caregivers receive from the provider. There are many transition periods as a person with CF enters adulthood. Teen years can be a time where sustaining daily care regimens isn't a priority and life can be very busy. I hear much about busy lives into college, then into work life as well, and discuss finding dedicated time for treatments, figuring out when to take pills, provide tools such as pill boxes as needed. I work to educate the teen about why their medications are part of their care plan, how they work. They don't work if you don't take them. Learning to order medications is an important piece of transition to adult, as well as how the assistance programs and grants work. And during pregnancy, medication safety is at the forefront. Pregnancy and parenthood are times to remind the importance of self-care. So for insurance, as I have mentioned multiple times so far, access to medications is an important piece of my job. And transitions to new insurance, changing from one type to another, these can cause large delays in access. They can mean a new pharmacy, new assistance program needs, such as copay assistance or grant support, and always require new prior authorizations. I communicate with pharmacies to problem solve and help with proper billing and authorizations. So with any new medication need, the pharmacist is there to provide education. What should you expect from this medication? What are the potential side effects? How do you use this thing? Do you have the tools you need to include this into your care regimen? There are care guidelines available for many of the CF-related comorbidities and are a helpful reference. Treatment of some of the comorbidities, including ABPA and NTM, include medications that may interact with others. There is drug level and toxicity monitoring as well. So pharmacists pay close attention to these regimens and help manage them. Some new bacteria found in sputum are correlated with a decline in lung function. So we try and get rid of them at first growth. Educating about and getting access to these eradication regimens, as well as picking an appropriate protocol for each patient, is a role of the pharmacy team. So treating exacerbations and antibiotic selection are a large part of the pharmacist's role. Taking patient preferences into consideration is important. History of what has worked, type of preparation, liquid or pills, how many times per day the medication needs to be given. Counseling about how to take to ensure the medication is maximized and how to minimize side effects. For IV antibiotics, there may be need for monitoring drug levels and doses, as well as monitoring for toxicity. Also, is this prescribed regimen feasible? Can the IV medications be given together at the same time? Is there enough time in the day for time off infusions? Is the person with CF going home and continuing their IV antibiotic care? Is this feasible for home? What should the lab monitoring schedule look like? When a person with CF starts treatment for other health issues not related to CF, such as hypertension, high cholesterol, or type 2 diabetes, I get a lot of questions about whether medications to treat those conditions are okay with CF medications. I speak directly with primary care providers or other specialists, or sometimes I provide my patient directly with the information about which medications are the safest choices. Then they can share this information with their other doctor. With advanced lung disease, the role of the pharmacist includes helping with symptom support, such as help with pain management as needed, or as management of exacerbations, as well as with optimization of care regimens to reduce symptoms and maximize lung health. Throughout each phase of life, I also help with mental health medication management. Are the medications safe to take with others? Do you feel like they are providing benefit without too many side effects? During your care for cystic fibrosis, your pharmacy team will assist with logistics and minimization of side effects. So you have time back to dedicate to what you love. Thank you.
Thank you so much, Corey, and thank you everybody for joining us today. Before we wrap up, I think it become really abundantly clear through just our conversation today, as well as I think a lot of the other topics that are going to be covered at ResearchCon, that CF care is changing rapidly and drastically. So I think we'd all love to hear from the panelists. What does the future of CF care look like to you? And for the audience, if you have any additional questions that you'd like us to touch upon, please feel free to put them in the Q&A while we're talking.
This is Corey. For the future for care teams, I'm hopeful that all centers will have a dedicated CF pharmacist and pharmacy team as a resource to help manage medication regimens, which are continuing to evolve.
This is Deepika. I think that one of the most exciting things as we keep growing as a community is watching the increasing engagement of people with CF and their families. And I love seeing that happen at all levels. So I know that care centers have adult advisory boards that are participating. And I love seeing that engagement because I really think that that shapes what we're doing as a care team. And I think it's the most direct way to inform and shape your own care at local levels beyond just your one-on-one with your care team. And I also wanted to echo from the chat that there were several mentions for community voice. And so I think, you know, the future of care teams really depends on the community's voice at whatever level those voices are coming in.
Perfect. Lauren, did you have anything from a patient's perspective in terms of how you think care teams or the care models are going to change, or a change you'd like to see?
As far as me as with the person who has CF that is Black, it is comforting to see a lot of diversity within the care team, and also just doing more events or conferences like this where we're always informed and educated about updates, research, and whatever is going on in the CF community just makes me feel better. So.
So we had a question come in from the Q&A. Thank you to all the panelists for your input. That was great. A question from the Q&A: as the outlook improves, what is involved, or are there considerations given in making sure guidelines are appropriate and not prematurely adjusted?
I can jump in and add a little bit to this. So my main job at the CF Foundation is to run all of our advanced lung disease and lung transplant programs. And so we have CF referral guidelines, and we've actually been having conversations recently because of the decreased numbers of people with CF who have needed transplant since Trikafta, and the decreased number of people with advanced CF lung disease since Trikafta. And at what point do we need to make changes to when we recommend people are referred for transplant? And we've decided for right now, it's too premature. We don't have enough data. And so I think the big overarching answer to that is we really do let the science and the data drive us. We have a steering committee for the guidelines development. So all that we do goes through the steering committee first before we decide. But yes, we do look at the guidelines periodically and see what needs to be updated. But yeah, we really wait for the science and the data to be available to allow us to make changes.
So Erin, I'm going to ask you if you can ask the question one more time so we can make sure we're answering it each.
The one that I just asked was, hold on just a second, let me find it. As Outlook improves, what is involved, and is there consideration given into making sure guidelines are appropriately adjusted but not prematurely adjusted?
So from my perspective as a care team provider and researcher, I think that, you know, this also goes back to, again, it came up in the chat that the input of community voice is incorporated into the guidelines. And so I think that the patient experience that is informing that is so important. You know, much of what we see comes from patient experience, whether it's coming through voice directly or through participation in the registry. And so I can't emphasize enough that it's because of all of you, it's because of people participating in the registry, it's because of people giving their input that ultimately we know what to do and serve you best, which comes back to serve you. So it's just with a lot of gratitude and kind of that point of, you know, keep speaking up, because it really does come back to shape your own care.
Thanks, Deepika. And another question that came in on actually one of our pre-submitted questions that you may also be able to cover. Do we know do specific mutations have a bearing on the lifespan and the perspective?
I could probably talk about this for another hour until I made everybody bored to tears, possibly. But this has been the subject of research that I've been looking at under my mentor and continuing since 2008. And so it was really well established even before that, that you could really take even people with 2 copies of the Delta F508 mutation, for example, and have a very broad spectrum of lung disease severity, where some people are living much longer and doing better in their lung function and other metrics of health, whereas others are struggling much earlier and moving on to transplant, for example. So we know that, not CFTR alone is not solely responsible for how somebody is doing with their CF once they have CF. And there are so many different factors that can play into that. We study non-CFTR gene modifiers, so there's other effects like inflammation and more. But then there are so many other effects that are outside of our bodies, like access to insurance, sticking with treatments. We have had so much in the research and development pipelines, but those drugs and therapies are only as good as the frequency of use for them. And we know it's challenging, which is why we're also studying in so many ways how to help people stick with their therapies. So I can get long-winded, but the shorter answer of that is that even amongst 2 people with Delta F508 mutations, 2 copies, we can see such differences in lung disease. And we know that 50 to 80% of that at least is coming genetically from non-CFTR genetics, but other studies have also shown that there's so much more that's going on outside of the body too.
Thank you so much, Deepika. Last call for any questions. It looks like the Q&A is just about done, and that's actually perfect because we are just about out of time. So I'd like to wrap up. But before we close, as I think a lot of folks have mentioned before, and I've seen it come up in the chat as well, community voice is really a great way to become involved in upcoming projects about CF across the lifespan, or a lot of other great things that are happening within the foundation and the community. Community voice really comprises people from across the cystic fibrosis community, with the idea that they'll bring their unique insights and priorities to the forefront of research, care, and programs. And when you join Community Voice, you receive tailored opportunities catered to your interests, from answering surveys to joining committees, and you can do them from home. This is how Lauren and I were able to participate in ResearchCon, and I can say it's been a really great experience. So look out for information on Community Voice, and please join if that's something you'd be interested in. But thank you very much to all of our speakers today for sharing your knowledge and your insight as we talk about bringing life to the lifespan. And thank you to everybody for attending and for all of your chats and questions. There are a lot of really wonderful resources related to this and other sessions on the session resource page. For this session, you'll find the slides we shared and other items the speakers thought you might find valuable in that resource. And again, the links to some of the care guidelines, as well as some other things that were discussed today, were in the chat. Please spend some time exploring the resources and download anything you'd like to keep.